Dr. Marisa Stahl is a pediatric gastroenterologist, and she's the director of research at the Colorado Center for Celiac Disease at the Children's Hospital, Colorado. Dr. Stahl's research focuses on celiac disease screening in both high-risk groups and the general population. She leads the celiac disease follow-up of children who screen positive in the Colorado Mass Screening Initiative, the Autoimmunity Screening for Kids, or ASK study. Dr. Stahl obtained her medical degree from Northwestern University in 2013, completed her general pediatrics residency at the University of North Carolina in 2016, and finished her pediatric gastroenterology fellowship and master's in clinical science at the University of Colorado in 2019, where she has stayed on since as an assistant professor of pediatrics. Welcome, Dr. Stahl, and thank you for your flexibility.
So thank you so much again for having me today. I'm really excited to be here and to share more information about the autoimmunity screening for kids study here in Colorado. So today I will be talking to you about why ASK, celiac disease mass screening and the autoimmunity screening for kids, or ASK study. And so in this talk, my plan is to describe the current landscape of celiac disease screening. I'm going to highlight the autoimmunity screening for kids, or ASK program, for celiac disease mass screening in Colorado. And then I'm going to detail the follow-up of screening identified children at the Colorado Center for Celiac Disease. So first, just a little bit of background on celiac disease presentation and screening, and this is really going to be focused on the pediatric population. So I want to start out this presentation by posing a question to the audience. Who on this slide do you think has celiac disease? Well, I think at least as healthcare providers, we're oftentimes thinking about the child all the way to the left of the screen who presents with classic symptoms of malabsorption, bloated belly, difficulty gaining weight, diarrhea, vomiting. But really, this is becoming much less common in terms of what we're seeing for initial presentation in the pediatric population. And really, the non-classic symptoms of celiac disease are becoming much more common. And what's pictured in the center of this slide is one of the non-classic presentations, dermatitis herpetiformis. And then what we are seeing more and more of in the pediatric population, particularly here in Colorado, where we have a lot of screening studies, are children that are subclinical, meaning that they have signs or symptoms in retrospect after going on a gluten-free diet, or children who are completely asymptomatic and are screened because they have a family member with celiac disease, or like the child on this slide who has type 1 diabetes. So the answer to that question is really that they all do, because the presentation of modern day celiac disease is incredibly heterogeneous. And this is really just to emphasize that, once again, it's no longer just the classic presentation. And particularly as healthcare providers, when we limit ourselves to thinking about celiac disease with these classic malabsorptive symptoms, we're going to miss a lot of children. And I think as the presentation is becoming more and more heterogeneous, clinical detection is becoming more and more difficult. And that's because as healthcare providers, once again, when people present with classic GI symptoms, things like diarrhea, constipation, abdominal pain, bloating, weight loss and growth issues, it's much easier for us to identify and think about celiac disease. But less than 1/3 of children are going to present with any of these GI symptoms. And really, the extraintestinal manifestations of celiac disease are much more common. And so there may be neurologic symptoms and signs, things like headaches. There may be more hematologic signs like iron deficiency anemia, fatigue, once again, rashes like dermatitis herpetiformis. There may be oral manifestations, things like aphthous ulcers and dental enamel defects pictured to the right of this slide, and it can even cause some cardiac manifestations. So really, once again, thinking and limiting ourselves to the gastrointestinal presentations of celiac disease make it more difficult for healthcare providers to identify. And to make things even more complicated, most people living with celiac disease may have no recognizable symptoms at all. And so I think some of this shift in presentation may be because we are better at screening for and finding celiac disease now. I'm just going to briefly review some of the tests that we have available, this alphabet soup, so that we're all on the same page for the rest of this talk. I think a really important point about this testing is that all the antibody testing that we use to screen for celiac disease requires that people are on a gluten-containing diet. Once people go gluten-free, these numbers normalize, and so it becomes very, very difficult to screen. And so the first set of tests listed on this slide are the anti-gliadin antibodies. These are really older antibody testing that have fallen out of favor because of the poor sensitivity and specificity of these tests. The tissue transglutaminase IgA, or TTG IgA, is really our preferred first-line screening test. You can see that this is a much more preferable test when you look at the sensitivity and specificity. The endomysial antibody IgA, or EMA IgA, is technically a more difficult test, and at least here in the United States is a send-out test, so it's not as readily available in all locations, but you'll see that it's a pretty specific test. And so sometimes we use it as an adjunctive to the TTG IgA. And per the European guidelines, at times this can even be used to diagnose celiac disease without a biopsy. An important thing about both the TTG IgA and the EMA IgA is that it requires patients to be IgA sufficient. And so for people that are IgA deficient, which is thought to be up to 8% of patients with celiac disease, the deamidated gliadin peptide IgG, or TTG IgG, are used as screening tests. And then the final test that is listed on this slide is HLA screening, which is genetic screening for DQ2 and DQ8, which is generally considered necessary to develop celiac disease, but is not alone permissive. So what you'll see from this table is that it's a sensitive but not very specific test. And what that translates to is that it has a really good negative predictive value. So if you don't have these genes, in some studies, it's less than 0.1% of people that will get celiac disease. So it's more helpful when we're trying to rule it out. So that was a very busy slide. And really the take home from that is that oftentimes when we're talking about celiac disease screening in the clinical setting, we are talking about the TTG IgA and measuring the total IgA level as the preferred first-line screening test for celiac disease. And with improved diagnostic capability, this slide shows the results of a meta-analysis of worldwide screening studies from 2018. And the point of this slide is really just that celiac disease is very prevalent when you screen for it within populations. And in this particular meta-analysis, the pooled worldwide seroprevalence of celiac disease was 1.4%. So once again, celiac disease is a common problem that occurs worldwide. And similarly, this meta-analysis also showed that celiac disease is becoming more common over time, and the incidence is rising. And so what you can see on this figure is that all the included regions in this meta-analysis, so all the different colors, and Canada is on here too, the incidence of celiac disease, which is on the y-axis, has been increasing over time, which is on the x-axis. And I think a really, really important point about these tests is that for individuals that screen positive by any of these tests for celiac disease, so there's heightened suspicion for it, you still need confirmatory testing in order to confirm a diagnosis of celiac disease. And this is really important to differentiate when we talk about different screening studies and what is used to screen for celiac disease and confirm celiac disease. And so there are currently two different criteria that we use for diagnosis. The North American criteria, which requires that people have positive serologies, a positive biopsy, and a positive response to the gluten-free diet. And what's pictured on this slide is just what we see on that duodenal biopsy. So you can see the picture on the left is healthy intestinal villi. And with celiac disease, those villi become flattened, and you can see total atrophy of those villi on the right-hand side. The other criteria that is sometimes used is the European guidelines or European criteria. And this requires that individuals have a TTG IgA that's over 10 times the upper limit of normal, and then a separate blood draw with that positive EMA IgA. The nuances and the differences of these criteria really could be a whole separate talk and is certainly not the focus of this talk. But once again, I just wanted to emphasize that when we talk about different screening studies, it is important to differentiate between a positive screen and a confirmed case of celiac disease. And so I've shown you that celiac disease is common when it's screened for, and that we have really good tests to help identify and confirm it. But really, why should we care? And so while this remains somewhat controversial for individuals who are asymptomatic at presentation, we know that celiac disease, if it's undiagnosed and goes untreated for a period of time, it can lead to several complications throughout the lifespan. And that's because having undiagnosed celiac disease, you have increased intestinal permeability, issues with malabsorption, issues with vitamin deficiencies, and issues with ongoing intestinal inflammation. And in the pediatric population, we can certainly see poor dental mineralization and subsequent dental enamel defects. It can lead to a lack of nutrient absorption. It can also lead to growth hormone deficiency and subsequent poor growth. And so particularly in our pediatric population, we can see short stature with undiagnosed celiac disease. It can lead to vitamin D deficiency, which is really, really important for bone accrual in the pediatric population. And later in life, this can lead to osteopenia, osteoporosis, and fractures. And then I think what often gets a lot of hype, although is very, very rare, ongoing mucosal inflammation can lead to certain premalignant states and refractory celiac disease and certain rare intestinal lymphomas. And so just with all of that in mind, why, a logical question to follow that is, shouldn't we consider mass screening for celiac disease? And celiac disease does meet many of the World Health Organization criteria for a disease that should be considered for mass screening. I just showed you the evidence on previous slides that it is common. We have good screening tests. There have been many publications describing the screening and diagnostic practices across different cultures. We know that it can be treated with a strict gluten-free diet, and that clinical detection based on the presence of symptoms can be very, very difficult. So where celiac disease really falls short with respect to this criteria is that the outcomes associated with untreated, asymptomatic and screening identified celiac disease are not well teased out. And at least here in the United States, the cost effectiveness of screening still is relatively unknown. So due to the lack of quality evidence for benefit for identifying and treating asymptomatic celiac disease, the USPSTF currently states that there is insufficient evidence to support general population screening for celiac disease. However, I will emphasize, and I think this applies to the United States and to Canada, that insufficient evidence does not mean that it should never be done. It just means that we really need more evidence and studies to delineate whether this is a good and cost-effective thing. And so this brings me to the autoimmunity screening for kids, or ASK study. And this talk will really focus on the screening effort here in the United States, specifically Colorado. But I do really want to acknowledge that there are similar screening studies across the world. And here in Colorado, we've been really, really fortunate to have wonderful endocrine colleagues who are experts in diabetes and have kind of helped lead the way in celiac disease screening here as well. And so one example of a very similar diabetes screening study in Canada is the CanScreen program. So once again, just acknowledging that these types of studies are not limited to the US, although I am going to talk about the results from Colorado. So the autoimmunity screening for kids study is a mass screening program for both celiac disease and type 1 diabetes here in Colorado. And we are screening at our children's hospital, at satellite locations, at private pediatric offices. And now we've actually expanded beyond the border of Colorado. And we're offering home kits and lab kits. And so I know that there have been children screened in New York and in Chicago. And so it's exciting that we're getting to expand nationally. It is currently screening children 1 to 17 years old. I think an important point about this and what's kind of different from some of the other screening studies here in the States is that you are not required to have a family history to participate in this study, and most children do not have a family history of diabetes or celiac disease who participate. The goal is to screen 50,000 children for tissue transglutaminase IgA or TTG-IgA, and then islet autoantibodies for diabetes. This program was fully implemented in February of 2017. And as we are expanding beyond Colorado, there's another program called Ask the Experts that is striving to do the following, particularly for celiac disease screening. We want to make sure that children, even outside of Colorado, have access to mass screening if wanted. And that they have access also to knowledgeable providers who can help with next steps when they screen positive in terms of the confirmatory process. And then we really feel like it is a right for all people who are diagnosed with celiac disease to have adequate gluten-free diet education, and making sure that there are providers in all these locations who are comfortable doing that. And so this slide just outlines the flow chart of our study in terms of the celiac disease screening pathway. And so children are initially screened for TTG-IgA at their initial visit. And with that visit, they fill out a very, very simplified GI symptom questionnaire. Any child that has a positive initial TTG-IgA is invited to return back for a confirmation visit within 6 weeks of that initial positive test. And at that time, we actually give them a full extended symptom questionnaire. And then if they confirm positive, at a lower level and don't endorse any symptoms, then they're referred to follow up with their primary care provider. If they have a higher positive screen, we were initially separating our follow-up protocol based on whether children had symptoms. And for a lot of reasons, ultimately decided that that did not make sense. And so now, regardless of whether they have symptoms or not, they're given the information for the Colorado Center for Celiac Disease, and it's suggested that they follow up with us. And I'm not going to get too much into the weeds talking about the actual assays that are used in this study, but I did want to make the point that for celiac disease screening, I think it's really, really important that we work with other autoimmune diseases, diabetes, thyroid disease, because when we work together, it actually makes our screening more efficient. And so what this slide demonstrates is a multiplexed assay that we use in the ASK study that can screen for TTG, IgA, islet autoantibodies all at the same time. And this has really actually cut costs for us and labor time by 30%. And really performs as well as the single assays when we're screening for just one antibody. So moving on to some of the results from our study, here are the results from the first 10,000 children that were screened through the ASK study that we published back in 2021. And what we found from the first 10,000 children that were screened was that 2.4% of children screened here in Colorado had undiagnosed celiac disease autoimmunity. And only 10% of those children who screened positive had a family history of celiac disease, and only 30% endorsed any gastrointestinal symptoms. So what we ultimately concluded from that is that there is a very high prevalence of undiagnosed autoimmunity here in Colorado, and that most of the children that have been identified through the ASK program would not have been caught by our current screening practices. And so we're a little bit further along now. We've actually screened over 33,000 children to this point, which is something we're pretty proud of. So what have we learned more recently from screening for both diabetes and celiac disease through the ASK study? And so of the over 33,000 children screened to date, 996 have screened positive, which is about 3%, and that's just accounting for that initial visit. Then 487 of those 487 of those who went on to their confirmation visit screened positive again out of 568 total who went for that confirmation visit. So that's about 85.7% of children who confirm positive at that second visit. And so when you extrapolate that to the initial number that I showed you, it actually works out to, once again, that 2.4% prevalence when you account for the confirmation rate. And amazingly, 255 children in the ASK program have a celiac disease diagnosis. Looking at the initial screen again, 45 out of 28,465 children actually screened positive for both islet autoimmunity and celiac disease autoimmunity. At our center, we think it's really important that our celiac disease patients also get screened for diabetes. So we do encourage our celiac disease patients to get screened for islet autoimmunity through this program. And 15 out of 271 children who were screened through the ASK study with a prior celiac disease diagnosis actually screened positive for islet autoimmunity. This number is definitely higher than what's been published in the past in terms of rates of islet autoimmunity among those with celiac disease diagnoses. And then on the flip side, 8 out of 649 children who are followed in the ASK study for islet autoimmunity subsequently developed celiac disease autoimmunity. So I'm going to shift gears a little bit now and talk about what happens for these children who screen positive through the ASK program and follow up at our center. So these children, as I showed you on the previous slide, if they screen positive in the ASK study, they're referred to the Colorado Center for Celiac Disease. And what I'm going to show you on the next couple of slides is the follow-up information data that we have from children who have biopsy-proven celiac disease or have celiac disease based on European serologic criteria. So have confirmed diagnoses and are following up at our center. And so in this protocol, we have a baseline visit. This is before they're on a gluten-free diet and have an official diagnosis. And at that visit, we collect some demographic information on family history, some information on their medical history. We do our routine clinical labs as we would for any other patient that we see in our center. We repeat that extended symptom questionnaire, and then we give them a few health-related quality of life questionnaires. And then at their follow-up visit, we repeat a lot of the same questionnaires again and same labs so that we're able to compare. This, I should say, their follow-up visit is after 12 months on a gluten-free diet, so a year later. And then in addition to all the information that we collect at baseline, we also do a formal gluten-free diet adherence assessment with our dietitian. And so the data I'm going to show you on the next couple of slides is from 42 children who ultimately completed follow-up in this protocol. And this slide here just compares the 42 children who did complete this follow-up protocol to the 10 children who had enrolled at baseline and were lost to follow-up, so did not complete that follow-up visit. And I just think it's interesting to point out that the children in this study that were lost to follow-up were more likely to be older, more likely to be male gender, more likely to be non-white race, more likely to be from less affluent households, and more likely to be insured by Medicaid. And obviously our healthcare system in the States is different than in Canada, but I do think that, loss to follow-up is a more global problem in celiac disease care. And so it definitely has created some food for thought at our center in terms of what we can do to help support better follow-up. And so for those who did complete follow-up, most of the routine labs that we collected at baseline were not abnormal, but you will see that there's a large proportion of patients who had iron deficiency at that baseline visit. And interestingly, after 12 months on a gluten-free diet, what this spaghetti plot shows is that for a majority of children, that iron deficiency did improve after 12 months on a gluten-free diet. And similarly, the hemoglobin also improved from that baseline to follow-up visit, although the clinical significance of this is less because it wasn't really abnormal for most children at baseline. One question many people pose is that if children are screening identified, will they stick to a gluten-free diet? And of the families that had an adherence assessment in our program, 26 out of 28 actually had good to excellent adherence when assessed by our dietitian at follow-up. So the answer to that question is yes, they can have good to excellent adherence. And then I think a really important take home from this study as well is what we've seen with symptoms over time. So this slide details the change in symptoms from that baseline to that follow-up visit, with points to the right of the dashed line indicating an improvement in symptoms after being on a gluten-free diet. And what you can see is that overall symptoms did improve with both respect to severity of symptoms and frequency of symptoms after 12 months on a gluten-free diet. And this slide is very similar, but it breaks down the individual symptoms that we asked families about. And what I want to call attention to is some of the symptoms that improved most markedly, including headaches and decreased energy or fatigue. Because I think these are not symptoms that are necessarily frequently prompting screening for celiac disease in the primary care setting, but definitely did improve on a gluten-free diet for many children in our study. A little bit more on symptomatology in this group. So at the initial ask screen, at that very initial visit, 29 out of 42 of these children denied any gastrointestinal symptoms. Amazingly, by the first time we saw them at the Colorado Center for Celiac Disease, 27 out of 29 of those children had symptoms on our extended screening questionnaire. And there were 38 children total who had reported symptoms at that initial baseline visit. After 12 months on a gluten-free diet, 33 out of 38 children reported improvement in one or more of those symptoms. And this really is not limited to the ASK study. I think it represents a huge misnomer in celiac disease care. It's really hard to truly differentiate asymptomatic from symptomatic, because oftentimes when children are actually asked about the multitude of symptoms that may be associated with celiac disease, screening identified children really do have symptoms. And once again, this has been corroborated in multiple screening studies. And this slide just shows the results from those PEDS QL questionnaires, which are a measure of pediatric health-related quality of life. And once again, points to the right of the dashed line indicate an improvement in quality of life. And what you can see is that overall quality of life also improved after treatment with a gluten-free diet. Although it is interesting when you look at the difference in the magnitude of that improvement based on whether the quality of life was reported by the caregiver or parent or was self-reported by the child. And so I think, there's still future analyses that we need to do to better tease out the differences between caregiver reported and self-reported quality of life, and then quality of life in the different age ranges that were enrolled in our study. And then I think another question that comes up with respect to celiac disease screening is, if we are treating asymptomatic individuals, are we actually going to make anxiety and depression worse by placing them on a gluten-free diet when they didn't have symptoms to begin with? And that is not what we found in our study. What you can see on this slide is that the results from our anxiety and depression questionnaires did not show that anxiety and depression were worse after a gluten-free diet in our screening identified cohort. And so that was a lot of information that I just gave you. And I think these slides are all going to be provided to you. But the main take homes in terms of what we have learned from children diagnosed with celiac disease through the ASK study was that many of them had iron deficiency at baseline, and that improved on a gluten-free diet. Many of them had unrecognized symptoms that did improve after treatment with a gluten-free diet. And then finally, quality of life actually improved after treatment with a gluten-free diet. And so here are the 3 things that I would like for you all to take home from this presentation today. The presentation of modern day celiac disease is incredibly heterogeneous and can be really hard to pin down clinically. And mass screening is a way that allows us to cast a broader net for diagnosis of celiac disease. In the ASK study, we found a high prevalence, 2.4% of undiagnosed pediatric celiac disease autoimmunity. And in the follow-up of children with confirmed celiac disease identified through the ASK program at the Colorado Center for Celiac Disease, we found that children improved after treatment with a gluten-free diet with respect to unrecognized symptoms, quality of life, and iron deficiency. And I just want to take some time to thank all the teams that this research would not be possible without. Once again, our endocrine and diabetes researcher colleagues over at the Barbara Davis Center, everyone at the Colorado Center for Celiac Disease, all of our partners at the Children's Hospital Colorado, and then most importantly, our Ask participants, their families, and our Ask provider partners, and of course, all of our sponsors who have helped us with moving this study forward. And with that, I'll take any questions.
Could you speak about the newest data around the percentage of kids who have false negatives for serological screening based on your research, and any suggestions for what can be done about this?
Yeah, so I think that that's actually a very complicated question. Sounds like it should be really easy, right? But there's definitely, so what we've seen is that there are some children that have an initial positive test that we consider it transient positivity, meaning that those antibodies go away over time. We see some children who have more fluctuating antibodies, meaning that those numbers go up and down over time. And in terms of actual false negatives, you only know it's a false negative if everybody goes on to get a biopsy. So if it came back negative initially, and then they get a biopsy, and that's positive, then it would technically be a false negative. Seronegative celiac disease, I think actually there was a study that was recently published from Canada. But at least with my clinical experience, it's pretty rare that we see that in pediatrics. And through the Ask study, we've had one case where the screen through Ask was positive. The clinical antibody test that we send at our center was negative, but their biopsy was actually positive. So I can't give you an actual percentage because not all these kids have been biopsied. What I can say is that it happens, but it's pretty rare, at least that we see that.
Well, thank you. And lots of interest in the type 1 diabetes angle. I'm going to try to combine a couple of questions here. So first, if you could elaborate on the link between pediatric celiac disease and the onset of type 1 diabetes, and whether there was any connection there's research out of Italy and the start of the intense screening that was announced earlier this year in Italy. Any comments on that would be welcome too.
Yeah, I think it's really amazing what has happened in Italy and the progress that they've made there. And that's something, we're really interested here in Colorado and in the states more broadly, and hope that we can bring something similar to fruition here. As I was saying, Ask is not the first study where diabetes and celiac disease have been close partners. There are many, many research studies where we benefit from including both disease processes. The data that I showed you today on islet autoimmunity screening in our celiac disease population, not all of those children, I should be very clear, have type 1 diabetes. So there's a spectrum of islet autoimmunity. You can have single antibody positivity, multiple antibody positivity. And so most of those children actually do not have type 1 diabetes. Some of them are definitely at higher risk based on multiple positive antibodies. What has previously been shown in studies is closer to a prevalence of 1 to 1.5% in our celiac disease population. It's typically the other way around. What we see much, much more commonly clinically is children get type 1 diabetes and then subsequently get celiac disease. And that's also been shown in the TEDdy study, which is a research study of children at genetic risk for both for diabetes and celiac disease. And so that study has followed these children over 15 years now. And what we have seen much more commonly is diabetes first and then celiac. But I think, it's clearly not a non-existent problem for the children that we take care of with celiac disease. And so that's why we push screening at our center, even if it still, is not certainly is not the common story for the children that do develop diabetes. I think now there's been an incredible amount of research and progress in prevention, and they actually have some medications that can delay onset. So I think that makes screening even more important in our population.
And so just to stick with diabetes for a minute, I'll ask this for the benefit of folks online who do not have a scientific background. I do not have a scientific background. So type 1 diabetes is an autoimmune disorder. Type 2 is not. I see you nodding. So I know there's been a lot of work on analyzing the connection between type 1 diabetes and celiac disease as both being autoimmune disorders. Type 2 diabetes, much more common, but less linked with celiac disease, at least at the pediatric level, maybe a bit more at the adult level. Anything you can comment on that? And first, was I correct in what I just said?
Yeah, that's a really, really good overview. Type 1 diabetes is the autoimmune form of diabetes, whereas type 2 is when you develop insulin resistance. I think a big push in the diabetes care realm is ensuring that children that we suspect have type 2 diabetes actually have type 2 diabetes and don't have those autoantibodies, and don't have type 1. And I think once again, that points to how hard it's become to differentiate these things just based on symptoms and clinical presentation alone, because as obesity becomes more of a problem, some of these kids may present with signs and symptoms of diabetes, and people just assume, hey, it's type 2 based on the clinical presentation. But really, type 1 diabetes in childhood, at least, it's very, very important to rule that out when we're seeing patients with diabetes.
Mm-hmm. Okay, thank you very much for indulging me there. I might jump onto mental health. So one attendee has two children with celiac disease who presented completely differently. So on the mental health side, anxiety, depression can be linked to celiac disease, we know too, and children as well as adults. If, in your view, like if children are presenting with serious mental health concerns, could a screen for celiac disease also be a good idea? I know, especially if maybe celiac is somewhere in the family.
Yeah, I absolutely think that a screen for celiac disease is a good idea. It's a really complicated relationship because we certainly see children who have mental health concerns at the time of diagnosis that do improve with a gluten-free diet. And then sometimes there are mental health concerns and they're diagnosed with celiac disease and they actually don't improve with treatment. They seem to be unrelated to the celiac disease. But I certainly think having a low threshold for screening in those scenarios, because we have seen many children get better when they go gluten-free, is important. And I also just want to emphasize that mental health support is incredibly important in celiac disease care. For that reason, but also just for support with the gluten-free diet. And we actually have all of the patients seen at our center, or encourage them as much as possible to also have a visit with our psychologist.
And on jumping to dental enamel, you mentioned about demineralization. Does this tend to occur during the formation or after eruption? And anything you could add on what causes it?
Yeah, excellent question. I feel like I'm really striking out with the questions today because we don't know. We don't actually know what causes it. There's a lot of different theories for this, and I know dentists who are trying to investigate this, but there's some thought that it has to do with malabsorption and possibly issues with vitamin D deficiency and just dental enamel formation. But then there's some that believe that it actually has to do with an autoimmune process with the teeth and antibody deposition, and just is yet another autoimmune manifestation. So we don't know the exact mechanism, but I think it's clearly something important for our dental colleagues to know about. And I have had dental colleagues refer patients for celiac disease screening based on dental enamel defects.
Mhm. And a couple questions on the islet autoimmunity. So if a child has been diagnosed with celiac disease with or without diabetic symptoms, do you think they should be tested for islet autoimmunity?
$1 million question. I would, the families that I counsel, I say yes, because we do have easy access to that here with the ASK study, and I refer them. Islet autoimmunity screening is not a part of routine clinical care or a part of any of our celiac disease guidelines currently. And it's typically ordered more as a research test. So while I think it can provide a lot of really great information, it's definitely not prime time in the clinical pediatric celiac disease care setting.
Thank you. And a couple questions more about the mechanics here. So I think you touched on this. How old were the children? How old was the youngest as well in your study?
So for the celiac disease arm of it, the youngest that we've seen is closer to 2. But we screen as young as 1. My daughter was screened when she was 1 because I think the more information you can get, the earlier on, the better. But
And a couple folks asked about whether they can access the extended symptom or screening questionnaire.
I did not put that on our slides, but Mark, I would be happy to share that with you to give to participants so that they can see the list of all the symptoms. I actually have a slide that shows all of that.
Okay, great. Yeah, Dr. Stahl did mention about sharing the presentation, so you'll probably send that around to everyone who registered for the conference afterwards. So just jumping ahead, you mentioned about increased ferritin, lower fatigue in some participants as a result of iron supplementation. Was the gluten-free diet alone enough to bring about that change? As like the links between those two, could you elaborate?
Yeah, so we actually didn't detail that in our data analysis. Definitely something we want to look at later. We have been interested in that question and have been trying to look at a different cohort for that. But I don't have the answer on that right now. Many of those kids were on additional iron supplementation, not all of them, but I can't give you the exact percentages.
Understandable. We like we talked about the false screenings or false positives or whatever earlier. For people who like they have one child is celiac, one is not, one's testing negative, but do you, in terms of screening children down the road that had tested negative, was any recommendations on that, and was screening siblings more than once part of your screening program at all?
So people are actually allowed to participate in the ASK program annually if they want to. So there have been several patients over time that have been rescreened. And I can't give you the exact numbers. I apologize today in terms of like how many of those rescreens came back positive. At our center, we recommend that siblings of celiac disease patients are screened every 1 to 3 years, at least for the first 10 years of life. And that is based on what we've seen in the TEDdy study, once again, that follows children at genetic risk. And what we've seen is that it seems like these children develop celiac disease most commonly in the first 10 years. And so that's why we recommend more frequent routine screening, but we acknowledge that you can develop celiac disease at any point in your life. And so for all family members over the age of 10, we recommend screening every 5 years.
Okay, thanks. And do you have any info on how many screened children who were diagnosed with celiac with no GI symptoms had cutaneous manifestations like chronic urticaria or psoriasis, for example?
There were a couple. I can't give you the exact numbers right now, but there were some that did not have GI symptoms and had dermatologic symptoms. There were definitely some, and I can't say specifically whether that was urticaria or psoriasis. We also see more like eczematous rashes and things like that too. But there were some that presented with rash.
Okay. Thank you. Some folks threw in questions that were more about adults. Just a reminder, Dr. Stahl is a pediatric gastroenterologist. But this is a more general question, and it'll have to be our last one. Can you speak about what any other conditions that could elevate the TTG levels besides celiac disease?
Yeah, so autoimmune diseases more broadly can increase that TTG level. So, diabetes is one that can increase the TTG. And sometimes we see that kids have a high TTG when they're first diagnosed with diabetes, and that number normalizes over time. Thyroid, different rheumatologic autoimmune diseases, so juvenile chronic arthritis, are some examples of other autoimmune diseases that can bump up that number.
All right. Thank you so much for taking the time. Thanks again for coming on early for us. We appreciate it. Thanks for joining us from Colorado.
Of course. Thank you for inviting me again. It's been great.